Hello, welcome to Life Matters. I'm your host, Brendan O'Connell. Well, oftentimes physicians that are in obstetrics and gynecology are on the front lines of I'll call it the abortion wars to some extent, because whether they're pro-life or pro-abortion, there's always that underlying tension that goes on with being in obstetrics and gynecology. And today, we have someone who used to live here in Roslindale section of Boston. And I just want to give you a little bit of background about her. Her name is Dr. Monique Chireau, and she's an assistant professor in the Division of Clinical and Epidemiological Research in the Department of Obstetrics and Gynecology at Duke University Medical Center. And she also had graduated did her residency at Yale University, and was at Brown University. She got her MD. This is in 1991, and also she got a master's in public health in 1991 from Harvard University. Well, welcome, Dr. Monique Chireau.
Thank you very much.
Dr. Chireau, I wanted to first ask you, I met you out at the Vitae Institute at Notre Dame University, and I wanted to ask you about what are some of the most pressing moral and ethical kinds of questions that OBGYNs have to deal with nowadays with, deliveries of babies and that sort of thing.
Sure, it's a great question, and I do have to offer my disclaimer that my views don't necessarily represent the views of Duke University, but I think that obstetrician gynecologists, OBGYNs, are really on the front lines of really what's a sort of cultural conflict regarding life. And specifically, there is a tremendous tension between the technologies that are used, for example, in vitro fertilization or somatic cell nuclear transfer, or now mitochondrial, the three-parent technologies that are being used. And in addition, so that's from the reproductive endocrinology aspect. From the perspective of birth, obstetricians are very much challenged in the area of extreme preterm birth, extreme prematurity, where decisions are made in conjunction with parents and neonatologists regarding the viability of a fetus who's born in the 22-week to 23-week range. And then finally, the questions of abortion and abortion technology, the limits on how far into gestation abortion can be carried out, are all very much in the minds of many obstetrician gynecologists. In addition, I think there are some very important questions around requiring residents in training programs to perform abortions or not requiring them to, and many discussions regarding whether abortion training needs to be a part of obstetrician gynecologist education so that they can be fully educated as OBGYNs.
And where does that stand now? Because I thought that medical schools for the last 10 or 15 years have been screening out applicants to medical schools that are pro-life. Is that true or no?
I don't think that that is true. I think that the questions come about more at the level of the residency programs, in that in certain residency programs, there's an expectation that residents will participate in abortion. And a lot of this came about through sort of guidelines and discussions that were occurring in the late 80s and early 90s. One of the ideas that was put forth was that if residents don't know how to do abortions, then they're not going to really be able to manage complications of pregnancy down the road. But in fact, abortion was largely illegal in the United States up until Roe v. Wade. Abortions were performed, of course, but abortion was largely illegal in the United States, and yet OBGYNs in that era were extraordinarily well-trained, extraordinarily skilled in the management of pregnancy and pregnancy loss. So it doesn't seem to me that there is a compelling argument that to be a well-trained OBGYN, you need to have training in abortion. I think at this point, most residencies do offer an opt-out sort of process where residents can opt out of being involved in abortion. However, I think it does need to be said that there is considerable pressure on residents to do abortions, and that remains generally a significant concern.
Mm-hmm. And are you saying that, I didn't quite understand, are you saying that you can be a good OBGYN without having done an abortion or knowing how to do an abortion, or are you saying?
That's correct, because the argument is that if you don't know how to do an abortion, you don't know how to complete a miscarriage. So let's say a woman miscarries early in pregnancy. The argument is that if you don't do abortions, you don't really know how to care for those patients. The fact of the matter is, as I said, that in the era before Roe v. Wade, abortions were largely illegal, even though they were being performed, and those obstetricians were very skilled. In fact, many of those obstetricians actually taught me and other generations of physicians how to do those procedures to address bleeding or a patient who was having a miscarriage and having complications from that.
Mm-hmm. And what about conditions like in high-risk pregnancies like preeclampsia? What goes on there, and is it just the mother you're concerned with, or the child also, and that sort of thing?
I think that as obstetricians, one of the things that you become introduced to very early in your training is that you have responsibility for two patients, and therefore the interventions that you're carrying out, you're constantly carrying out being mindful of what the impact of that intervention will be on both the mother and the child. So to give you a very straightforward example, women frequently are very nauseated early in pregnancy, and we give them medications to address that nausea. Mm-hmm. In that process, we screen those medications for their potential effects on the fetus because of the issue around thalidomide, which was a medication that was used to which women were exposed back in the late 50s and early 60s, that resulted in very significant congenital abnormalities. And so there's always that sense of being mindful and and thinking hard about what the impact of our interventions will be on both the mother and the child. Now, I have seen where the reality of taking care of two patients at once can be distorted into thinking that there is an ethical conflict between the mother and the child, and I don't think that that's true at all. When you're dealing, for example, with preeclampsia, the overall perspective is that what is going to be good for the mother is going to be good for the child. That calculus, that way of thinking about preeclampsia changes around the mother's condition. For example, if the mother becomes very, very ill, sometimes you as physician are put into the position of having to deliver that infant before viability. Now, this is where I think things become very confused in terms of, is that an abortion, and is abortion required, is it necessary for the life of the mother? The fact of the matter is that when obstetricians make a decision, for example, to perform an intervention, the goal of the intervention is to preserve the life of the mother and to preserve the life of the fetus if possible. I think this is referred to as the ethical principle of dual intent. If you look at the strict definition of what an abortion is, the definition of an abortion is a procedure whose objective is to kill the fetus. So when you are performing a delivery in a woman, for example, who has porphyria, or a woman who has severe preeclampsia before viability, your objective is not to kill the fetus. Your objective is to help the mother. It may happen in the process, if you're carrying out your intervention or your procedure, that the death of the fetus occurs, but that is not the goal of your procedure, and therefore it is not an abortion. Mm-hmm. Another example is a woman who has very severe heart disease, valvular heart disease, who may need to go on bypass. the fetal mortality for when a pregnant woman has to go on to bypass, the fetal mortality is about 30%. And so when the woman goes on bypass, the likelihood is high, it's not 100%, but it's high, that the fetus may die as a result of that intervention, or may have severe complications. But at that point, your goal is not killing the fetus. Your goal is preserving the life of the mother and hopefully to preserve the life of the fetus.
Mm-hmm. I see. And you mentioned that technology is making big advancements also in your field of obstetrics and gynecology. How so? Like you mentioned the mitochondrial issue. I believe that's what, three parenting, or we're now having three parents instead of two. It's mind-boggling for me.
Yeah, and so I think this is a technology that there were discussions about the mitochondrial manipulation. And most recently, this was discussed in some detail at the American Society of Reproductive Medicine, because these are technologies that involve the having to use DNA from three parents. There are a couple of issues around why this is a lot of ethical questions. This technology was debated in the United States, was debated in the United Kingdom, and in the United Kingdom, lawmakers did vote to allow fertility clinics to use these, what are called MMTs, mitochondrial manipulation technologies. But our FDA in the United States, as often is the case, I might add, is being much more conservative and is insisting on preclinical research. And there are several concerns. One is that the technology permanently alters the germline. In other words, it permanently alters DNA in fetuses, well, not fetuses, embryos, that are produced through this research. And there's really no prospective data, no clinical trials as to what the long-term effects of that will be. We simply don't know. And as you can imagine, there are possibly some very significant ethical and moral dilemmas with that in making permanent changes to the DNA, to the germline of that embryo, fetus, baby, child, adult, and hence their offspring.
Mm-hmm. And on in vitro fertilization, for instance, the Catholic Church is against in vitro fertilization. Is that has been a real growth industry, and no pun intended, but are there still moral and ethical discussions going on in that regard, or I
think there are, and that sort of links back in a sense to the issue around the three parent, or what I would call the MMT, mitochondrial manipulation technologies. One is that there are a lot of ethical concerns, I think legitimate ethical concerns, which I share, around working with human embryos. And in the United States, as I'm sure you're well aware, the Dickey-Wicker Amendment of 1995 prohibits the creation or destruction of human embryos used in any research that's funded by the Department of Health and Human Services, including the National Institutes of Health. And so with in vitro fertilization, I think that there are a number of concerns, some of them theological from the Catholic perspective, but others ethical as well. And one is that what happens to embryos that are not implanted back into the mother? This has led to a number of very high-profile court cases regarding one parent or another suing over whether they should have the embryos or not have the embryos, and if either parent could not have the embryos, and should the embryos be destroyed. And, of course, the principal question relates to, does life begin at conception? And there is obviously strong moral and philosophical as well as religious sense and conviction that life does begin at conception. There's no such thing as a fertilized egg. Once fertilization has occurred, the embryo, which is a unique, very immature human being, but human life nonetheless has come into existence. And so therefore, that human life needs special safeguards. And very interesting along those lines of, is an embryo really human life? In which case I often ask, well, what kind of life is it? Is it dog life? Is it cat life? And what kind of life is it? But along those lines is a very important question. It's a very important question that needs to be asked. And if you look at the very remarkable story, I can't go into great detail about this, but it's a story that unfolded in New Orleans post-Katrina, where the, in 2007, in the hospital in New Orleans, there were 1,400 human embryos frozen in liquid nitrogen in the hospital, and a number of Louisiana and Illinois state police officers actually risked their lives to reach these embryos and safely transport them out of New Orleans during Katrina. One of those embryos was subsequently implanted, and the mother gave birth to this young child. So that kind of answers the question in my mind as to whether a human embryo is human life, because these individuals would not have risked their lives to try to save these frozen human embryos if they were not truly alive. Mm-hmm. So getting back to your question about in vitro fertilization, I think that there are moral and ethical concerns. It is clearly a growth industry in terms, again, to borrow your pun, in that it's highly profitable. The cost of a cycle of in vitro fertilization ranges from anywhere from $15,000 to $25,000 per cycle, per monthly cycle, and most women need 3 to 6 cycles to get pregnant. So clearly, there are a lot of finances involved, and as well as some significant ethical questions.
Do you see, I know that we have, I think in this country, because we allow multiple embryos to go into liquid nitrogen, and I think we're up around 600,000 or more frozen embryos. Do you see snowflake babies as becoming the next big area where people are going to be, hoping to conceive children or have children? And are there ethical concerns with snowflake babies, particularly if there's purveyors who are nefarious, because it's a lot cheaper than in vitro fertilization?
So when you say snowflake babies, are you referring to embryo adoption?
Yes.
Okay.
Embryo
okay.
adoption.
Sure.
I interviewed a lady out of the state of Washington who was, I think she had the 11th snowflake baby, and then she provides an adoption service, actually, and she tries to do it very ethically, but I can see where that might not be, people trying to make big profits off of something like that.
I think it's a very, very complex issue, and as is often the case, the introduction of in vitro fertilization, while certainly viewed as a blessing for couples who have been unable to conceive, there's no question that it's led to these sort of ethical conundrums. I think that one of the discussions, and I've certainly been present with patients who've undergone these discussions and were considering whether or not to do embryo adoption. One of the ethical issues involved is, given, as you noted, the very large number of frozen embryos who are not likely, their parents are not likely to want to have those embryos necessarily implanted, or, as I was mentioning earlier, the husband and wife, or not even sometimes husband and wife, boyfriend and girlfriend, have broken up or become estranged and want the embryos to be destroyed or disposed of. The idea of embryo adoption, I think, came about out of a desire to see these embryos, in a sense, adopted, where they would not be destroyed. And so sort of ethically and morally, the question was, can you avoid the greater evil of destroying these embryos by then making them available to parents who would like to adopt them? And as is often the case, because we live in a fallen world and we are created in the image of God, but we sin, it has the potential to lead to exactly what you're describing, the types of abuses. Does that mean that it should not be done? That's a good question. I do think that ethically, again, the concern had been to avoid the destruction of life. But again, the possibility is always there that there could be abuse and there could be trafficking. There could be, in the same sense, although not with the same moral impact as oocyte egg trafficking is clearly something that's going on in different countries in the world.
Mm-hmm. And what are, as far as someone who'd be looking to get into becoming obstetrician gynecologist in the future, how would you counsel them as to, from a pro-life perspective? Would you make them wary of certain traps that are out there in the OBGYN milieu?
I think that's a really important question. I'm really glad you asked. I personally feel that OBGYN is a wonderful specialty. I approach my workday excited about what I'm going to do. There are a lot of intellectual challenges. There are a lot of research challenges. It's a clinical field that's just really, it's a good specialty to go into. I think the main cautions, and again, this is not necessarily limited to someone who's pro-life from a Christian perspective, because I'm a member of the American Association of Pro-Life OBGYNs, and we have members who are Muslims, we have members who are Buddhists, we have members who are Hindus. But I think I would approach training in OBGYN with a very firm sense of what your moral stance is. I think that you should understand ahead of time, if you are a pro-life physician, you're going to walk out your convictions, walk them out with the assurance that this is what, you are not going to compromise on your standards or your beliefs. And I can't speak from the Hindu or Muslim or Buddhist perspective, but I can speak from the Christian perspective that the authority of Scripture, the weight of Scripture, is in your favor. That it's very clear from Scripture that God knows individuals even before they're born. He calls them to their specific destinies before they are born, and that it is wrong to abort them. Mm-hmm. Having said that, it is also very difficult to maintain your convictions during training because there can be intense pressure to compromise and participate in abortions. What I would say to people is that as a person with a pro-life view, you have a unique contribution to make to the field. And I think it's really important to recognize that 83% of OBGYNs do not do abortions. You know, the estimate is that only 9 to 17% of OBGYNs perform abortions. So the majority of obstetrician gynecologists do not perform abortions. And that may not be the perspective or the perception that people get. But in fact, it's only a minority of practitioners, OBGYN practitioners, who do that. So I think I would advise students, I would advise residents to decide on your moral stand ahead of time, get support. There are some excellent pro-life organizations out there that will support trainees, and make a decision that you're going to make a contribution to the field by upholding a culture of life and not participating in the culture of death.
Mm-hmm. Well, Dr. Chireau, thank you so much. I can't believe our time is up. already, but really
Oh, already? Okay.
I appreciate your insights for this whole field, and also, you're right there on the battle lines, day in and day out. I guess it's you have the experience of having done it for quite some time, and know the machinations of the ebb and flow of the baby business. And hopefully you'll continue on in that regard, and look forward to our paths crossing again. Thanks so much for being on the show.
I look forward to that too. Thank you so much for the privilege of having me on your show.
Thank you. And we hope you found today's show to be unique, informative, content-rich, truthful, and thought-provoking. Thanks for watching. I'm Brendan O'Connell, your friend for life. Hello, welcome to Life Matters. I'm your host, Brendan O'Connell. Well, in recent years, I've been going to the National Right to Life Convention, and they have this incredible contest from winners from around the states, the United States, on the National Oratory Contest. And it's a very impressive group of people that have to compete against each other, and I think they also make a few friends while they're there doing it, and learn a lot about what's really going on, both in the teenage area, but then also in the adult area regarding right to life issues. And we're very fortunate that this year the winner is from the Northeast, Rhode Island, in fact, and her name is Safi Lamine.
Yeah.
Welcome, Safi Lamine.
Thank you so much. Thank you for having me.
Safi, how did you get involved with the Right to Life movement, and then also how did you get involved with the oratory contest?
Well, my mother taught me from a young age the pro-life movement and everything about it, and she really is the one that encouraged me to join the pro-life movement and Rhode Island Right to Life and all that. And so ever since I was a little girl, I've always been out on the sidewalk with her, doing sidewalk counseling and like holding up signs and like